So we have an adult client who's taking digoxin. This is considered a false stem question, right? Which statement indicates a need for the nurse to reinforce teaching? So the client is going to say something that is wrong, and the nurse is going to have to identify that and then reinforce teaching about digoxin. What are things you know about digoxin? Tell me in the chat. What do you have to monitor with digoxin? Heart rate. There's a therapeutic range, so patients can become dig-toxic. All right, let's look at our answers here. All right, so the correct response here is number 3. So this is not a diuretic. So if the client said that, we would want to further educate them about this. Remember that this was asking us for which statement indicates a need for the nurse to reinforce teaching. So something that was incorrect, that the client would say that was incorrect. Okay? 1, 2, and 4 are all correct statements. They should have periodic blood tests done because digoxin has a toxic level. So they need to have their dig levels checked periodically to make sure that it's okay. They also need to have their potassium monitored because potassium levels in can affect digoxin levels. They should check their pulse, their heart rate. If it's less than 60, they should hold the dose. And their St. John's wort should not be used any longer because it can affect the levels of digoxin in the blood. Let's talk a little bit more about digoxin here on this slide. It's also on page 37 in your book. So if you're struggling with that, this is something, again, to jot down in your notes, right? I want to review digoxin in greater detail. So it slows and strengthens the heart rate. Okay, so that's innately what it does. We use it most typically for patients who have heart failure or dysrhythmias, or both. So it can strengthen the hearts and increase cardiac output. That's how it works with heart failure. And then we can use it in atrial fibrillation and atrial flutter to slow the heart rate a little bit so that the ventricles get better filling before they contract. Because when we have atrial fib or atrial flutter, the atriums of the heart are no longer communicating with the ventricles. So we're not getting good filling of the ventricles. Therefore, the ventricles pump before they're really full and there's decreased cardiac output. So we use it to slow the heart rate a little bit to get better cardiac filling. We want to monitor for signs and symptoms of CHF, always monitoring that apical pulse before giving it, even we're educating patients to do that. And then we're monitoring potassium levels and toxicity. The most common signs of toxicity are related to the GI system, okay? Loss of appetite, nausea, vomiting, abdominal pain, and then CNS symptoms, fatigue, a yellow halo around the vision. And someone said that, Asia said that in the comments. Therapeutic level, 0.8 to 2.0. And there's a whole page in your book as well that's coming that lists all the therapeutic drug ranges you should know and the lab values, okay? Let's talk about nitroglycerin a bit. So, action of nitroglycerin. Nitroglycerin has an effect on both preload and afterload, meaning that it relaxes the ventricles so they can fill better, and then it relaxes the aorta so that the ventricles don't have to pump as hard to get the volume out. That's the definitions of preload and afterload, okay? Routes, it can be given many, many routes. One medication that is given probably some of the most different routes. So sublingual, translingual, transmucosal, those are all in the oral cavity. Then you can give it as a topical ointment or a transdermal patch, which are both through the skin. Then we can give it orally, or we can give it IV. Okay, so many different routes that we can give it. Really, injectables like sub-Q or IMs are really the only routes that we can't really give this. I guess we don't give it rectally either. We're going to monitor for signs and symptoms of hypotension and tachycardia because it's a vasodilator. So it's a very potent vasodilator, which is why we use it when patients are having chest pain related to MI, right? Chest pain indicates lack of oxygenated blood to the tissue. So if we give nitroglycerin, it vasodilates the cardiac vessels, allowing oxygen-rich blood to get to the heart tissue, decreasing then chest pain. But because it vasodilates everywhere. And so the patients can become hypotensive and tachycardic because of it. And very, very common headache. But if our chest pain is the problem, we don't often care about the headache. I mean, we tell patients about it. We feel sorry for them. We might give them an ice pack. But more importantly, we're worried about getting oxygen-rich blood to the heart. And if they take it for angina at home, they can actually become tolerant to it. So they might need increased dosages. Let's move forward. So remember I said in the beginning, we're going to change topics quickly, okay? I'm sure you're seeing some of that now that we're really into content. We're moving very quickly amongst these topics. And I know that sometimes can be challenging to kind of shift gears. And that's why it's important to not think we got to write every little thing down, but just write down little bits and pieces of important information and know what you need to come back to review. So this client is prescribed atorvastatin. Which laboratory test result should the nurse recognize as an adverse response to therapy? Atorvastatin is a statin medication. We use this for cholesterol lowering. Okay. Let's see what you guys think. Look at those keywords. See what you think. I'll put the poll up in just a second. All right, so the correct response here is number 3, an elevated CK level. One of the most typical complications that we talk about with our statin medications is unexpected rhabdomyolysis or unexpected muscle breakdown. Some patients experience this and it can be very, very severe. So what we educate them about is when they start this medication, if at any point they develop muscle pain, muscle fatigue, almost flu-like symptoms, not a fever, flu-like symptoms, but just the body aches of like flu-like symptoms, they should contact their provider right away. It's important because people can shake it off, try to explain this or that, why their muscles are sore. I was lifting this, I was shoveling, I was doing this. But in the meantime, this medication is breaking down their muscle tissue, causing this elevated CK level, which can then go on to wreak havoc in other issues, other parts of the body, like the kidneys. So we would check their CK level. If at any point you have any questions about what I'm saying, just hop on the chat and let me know. Let's talk a little bit more about these anti-cholesterol medications. So when we think about these medications, specifically our statin medications, we are going to be monitoring their HDL, their LDL, their total cholesterol, and their triglycerides. We're going to monitor those to determine if the medication is being effective. Then, of course, we're going to monitor liver function and that CK level to determine if they are experiencing adverse effects. One food that needs to be very, very cautious with these medications and many of our cardiac medications is grapefruit. So grapefruit is going to decrease effectiveness of this plus many classes of our cardiac medications. And it's not like with Coumadin or warfarin now where we say, okay, just eat like a normal amount of vitamin K rich foods. We really say no grapefruit for these patients. All right, let's move in and talk about some medications related to the respiratory system. So these are going to be on pages 39 to 41. Let's do a question to get our brain thinking about respiratory. So a client uses an albuterol inhaler during an acute asthma attack. Which findings should the nurse expect? So this isn't talking about adverse effects necessarily. This isn't talking about contraindications, right? This isn't talking about which findings should the nurse expect. And it's a select all that apply. So use your true false strategy as you work through it. All right, so the correct responses here are 3 and 4. So albuterol inhaler is a bronchodilator, okay? So it's going to open the airways, decreasing the constriction,
which I don't know why.
Thereby decreasing the wheezing, and we should then have a normal respiratory rate. It does not cause drowsiness or hypokalemia, and it does not affect the apical heart rate. It does cause tachycardia potentially. It can cause a little bit of palpitations, but those are adverse effects, not necessarily what we would expect. Okay? All right, let's review some other medications to promote air exchange. So we have things like beta-2 adrenergic agonist. You'll begin to find that as the day moves forward, the last hour or so, I'll get caught up in my words after talking for so many hours. Sometimes I even make up my own words because I'm moving so fast. So these medications are going to end in this EROL. Okay, so albuterol, just what we talked about. Okay, levobuterol, formoterol. Okay, those are beta-2 adrenergic agonists. These medications are contraindicated with tachydysrhythmia, so any cardiac dysrhythmias that are tachycardic in nature, because a side effect of them is tachycardia. Glucocorticoids are another medication that we can give inhaled to promote air exchange, so they decrease the inflammation in the lungs. But just like giving any other type of steroid, an abrupt stopping of them can cause Addisonian crisis, because our body innately produces glucocorticoids. But when we give them to patients, the body stops producing them and just allows the medication. So when we come off these medications, we have to slowly come off of them so that the body will start producing them on their own. When we have chronic usage of these, then we can go the other end and we can actually put a patient into Cushing's syndrome. Okay, both of these we're going to talk about in Med-Surg tomorrow. We'll talk more about those. Methylaxines can cause a rapid heart rate. So some common medications in this class are theophylline. Theophylline is a very common medication here. Therapeutic levels of these medications, it's really one of the only respiratory medications that has a therapeutic level. We want to make sure that these stay between 10 and 20. And again, in your book, there's a whole page that lists out these. Okay, so you could jot down the name like theophylline and know, like, okay, I'm going to add this to my list of medications that have a therapeutic level that I need to know. Then there's medications that we can use to promote airway clearance, and those are really on page 41. And here's the different classes that are there. So antitussives suppress cough. Things like codeine or non-opioid antitussives like dextromorphan. That's very common in over-the-counter cough syrups. Okay? Oh, wrong button. The other things are expectorants or mucolytics. Both of those increase the ability to move secretions out, right? So expectorants makes coughs more productive. Mucolytics make mucus more watery. So expectorants are things like guaifenesin, and mucolytics are things like acetylcysteine. Decongestants then are just that. They decongest typically the nose, the mouth, the throat. Phenylephrine or pseudoephedrine. Important to note that those can cause elevated blood pressure. So patients who have hypertensive should take something like Coricidin HP, which is directly for patients who have high blood pressure. Then antihistamines, things like diphenhydramine or Benadryl, can also clear the airway because they're going to decrease histamine formation and inflammation, but they can be very, very sedating in nature. All right, let's move right into the endocrine system. First, talking about diabetics, okay? So we have type 1 and type 2 diabetics. We're going to talk more about those differences, type 1 and type 2, tomorrow. But in general, we have to kind of remember that our type 1 diabetics always have to have insulin, right? We can only decrease their blood glucose levels by insulin because they have no insulin. Their pancreas have stopped secreting insulin. Our type 2 diabetics, on the other hand, still typically secrete a little bit of insulin. And what the real problem with them is that their cells are not sensitive to insulin. So we can give oral hypoglycemic agents to help increase sensitivity of the cells and help the pancreas secrete a little bit more insulin. Yes, we may give them insulin as well. That's okay. But our type 1s never get oral hypoglycemic agents. They only ever get insulin. Which diabetic medication did we say cannot be given with contrast dyes? We already covered this once. Tell me in the chat. Yes, metformin, exactly. So metformin has to be held 24 to 48 hours before, 24 to 48 hours after, ideally. Of course, sometimes patients come in an acute condition, they took their metformin that morning and they need a CT scan, right? So then we just flush with fluids, we watch their kidney function, we do the best thing we can to protect their kidneys. Why might we change a type 2 diabetic from an oral hypoglycemic to insulin? Why might we do that? Yeah, we're not getting the results that we expected, right? Maybe the oral hypoglycemics are not working as well anymore. They might have worked for a period of time. A lot of times they might need the addition of insulin at some point. All right, let's talk about thyroid medication. So we're either going to treat hypothyroid or we're going to treat hyperthyroid. And so hypothyroid is a patient who doesn't have enough thyroid hormone, right? So we are going to give them levothyroxine or Synthroid to increase thyroid hormone in their body. What we need to take into consideration most is that these patients need to take this early in the morning on an empty stomach with just water about an hour before they eat or drink anything. This will help even get them moving in the morning. Some patients set an alarm, take it at 5 a.m., go back to bed, wake up, and then they have the energy and the metabolism is going that they need to get going with their day. Because the thyroid really controls metabolic processes in the body. If we give too much thyroid medication, then we have symptoms of hyperthyroidism, tachycardia, tremor, nervousness, heat intolerance, all symptoms, diarrhea, all symptoms that their metabolism in their body is moving too fast. Hypothyroidism signs and symptoms, things like constipation, right? Weight gain, hair thinning, slower heart rate, brittle nails, yes. So in our hyperthyroidism patients, we have a couple of options. We can give things like methomazole, which blocks synthesis of thyroid hormones, or we do things like give radioactive iodine, okay, to actually destroy thyroid tissue. Lastly, we can just take the thyroid out. Sometimes when the thyroid functions too much, it's easier for us to just go in, take the thyroid out, and then treat the patient with thyroid hormone, right, that we can control. It's easier for us to control it like that. All right, let's talk about some hematological medications. Let's look at a question. 1 hour after a blood transfusion is initiated, a client reports difficulty breathing. Which action should the practical nurse implement immediately? All right, so we have an adult client. Tell me in the chat, what is the issue? Not what it says in the question. Think about what it's telling you in the question. What is the issue? Not what we're going to do. We're not there yet. What is the issue? What is causing the difficulty breathing? I know that's what it says. It says they're having difficulty breathing. What is causing it? Okay, so it could be a reaction. What else could it be? It also could be fluid overload. So the two kind of complications that we see most typically are a transfusion reaction or fluid overload. Okay? This is a priority question, right? Which action should the practical nurse implement immediately? So you're going to know that there's going to be some, probably multiple things that you could do and are right. You have to figure out what are you going to do immediately. All right, let's look at these answer options. All right, so the correct response here is number 4. A lot of people want to pick number 1, and that's very common because people want to get more information. But in this case, we don't really need more information. The client's having difficulty breathing. Getting a set of vital signs is not going to change our action, right? Our action is going to be to report the information. The RN needs to see this client and do a more detailed assessment to find out what is going on.
Oh, that would be 3.
This is a classic example of thinking about the nursing process and saying, do I have enough information to act or do I need more information? Would getting that additional information change what I'm going to do at all? It's not going to change it. Okay, so here we already have enough assessment data. How is compatibility determined when we give blood products? How do we decide who gets what kind of blood? Because a blood mismatch is the worst type of transfusion reaction to have. Okay. So we type and screen a patient, right? We take a sample of their blood, we send it down to the lab, and the lab tells us they're A, B, or O, right? Or AB. And do they have RH factor or do they not have RH factor? Okay, so those are the things that we think about and that we consider. Then the blood bank decides what type of blood they could get and how it is going to, if it's going to be okay for them. So O negative patients are the universal donor, meaning that anybody can receive their blood, because they don't have any antigens on the surface of their blood cells. So in a patient who has A blood, if you thought about their blood cell, if you thought about their blood cell like this, on the outside of their blood cell, they'd have little A antigens, right? They're surface antigens. Other cells of the body can then determine what kind of cell that is. If you have B, you have B antigens. If you have AB blood, you have A and B antigens. But if you have O blood on your blood cell, there's no antigens. So that way, if we gave somebody who has AB blood, O blood, their body doesn't recognize it as foreign. There's no antigens on the surface of that blood that make the body recognize it as foreign. So the opposite then is true in the person who is the universal donor. So the universal donor is O negative, meaning they can give their blood to anybody else. AB positive is the universal recipient. They can receive any type of blood because they have A antigens, they have B antigens, plus they have Rh factor. So they could get O negative, they could get O positive, they could get A positive, A negative. Because they already have all of the surface antigens, they can get any kind of blood. So those are the most typical things to think about when we talk about type and screen and compatibility determination. When we give blood, a lot of what we're doing is monitoring for transfusion reactions. Most typical transfusion reactions can be allergic reactions where they just have some itching, all the way up to a hemolytic transfusion reaction where they get the wrong type of blood, and that blood is being destroyed in their body. Their body is recognizing it as foreign, is attacking it, and is breaking it down and causing it to then hemolysize, we call it. And the body is going to have to deal then with all that broken down blood, and it's not going to be good. When we have a transfusion reaction or suspected transfusion reaction, as you guys said on that last slide, we're going to stop the transfusion. We're also always going to send the transfusion, the whole bag of blood, the tubing and everything back down to the lab for analysis. They want it all so that they can try to determine, why did that patient have a reaction? Do you guys have any questions about blood transfusions? You need to know all of the things blood transfusion related, but having some working knowledge of blood transfusions is good. All right, so iron preparations are a way then that we can help patients who have anemia. Iron deficiency anemia is the most typical type of anemia that we see. So in the chat, tell me what increases and decreases oral iron absorption. So if we're giving somebody oral iron supplementation, what are some things that might increase or decrease it? Anybody? Okay, with or without food. So ideally, we give it without food. It's best absorbed without food, but a lot of people do not tolerate it without food. So if we give it with food, we may just have to give bigger dosages. Vitamin C increases absorption, so giving it with a little glass of orange juice is actually really good. Calcium, on the other hand, as well as antacids or teas or coffees, decrease absorption of it. Right, so just a couple of things to think about. We just covered these here. I think we just talked about the GI system too, so it might upset the stomach. And then the other piece of that is to think about, it might change the color of the stools. How might it make the stools look?
Dark and tarry.
Almost even black.
Mm-hmm.
And so that's important to educate people on, because it might freak them out. And it might constipate too, Charles. Really, really great point there. And when we have a GI bleed, the stools also look black.